Good evening, everyone. I'm Chris Haramy, respiratory therapist and certified respiratory educator at the Lung Health Foundation. Welcome to part 2 of the COPD series on diagnosis and assessment of COPD with Dr. Durzo and Dr. Heffernan, sponsored with an unrestricted grant by AstraZeneca Canada. Before I introduce our speakers, I'd like to go over some housekeeping. The session will be recorded and a link will be made available to all registrants. We ask that you please remain on mute during the presentation and use the chat function for your questions. There'll be a Q&A after the presentation where you can raise your hand and come off mute to ask questions. I have the pleasure to introduce our speakers for tonight, Drs. Durzo and Dr. Heffernan. Dr. Anthony Durzo is an associate professor at the University of Toronto, a utopian researcher, which is in the Department of Family and Community Medicine at U of T, and director of the Primary Care Lung Clinic in Toronto. He has a very keen interest in promoting respiratory health in primary care and has had the opportunity to do so at local, national, and international levels over the last 30 years. Dr. Durzo was very actively involved in clinical and pharmacotherapeutic research in the areas of asthma and COPD management. He enjoyed being a member of the very important Canadian Asthma Guidelines Committee and the CTS COPD Guidelines Committee as well. Since 1994, he has worked closely with the Lung Health Foundation and the Ontario Thoracic Society on many exciting collaborative projects. He has published articles relating to respiratory health in leading peer-reviewed journals. He enjoys being an editorial board member of various peer-reviewed medical journals and the recently formed Utopian Respiratory Health Working Group at U of T. He's enjoyed his role as the Associate Director of the Health Science Research Component in the undergraduate medical curriculum at University of Toronto Medical School. Welcome, Dr. Durzo. Dr. Michael Heffernan is a staff cardiologist at the Oakville Trafalgar Hospital. He obtained his honors bachelor's degree in biochemistry and genetic engineering from McMaster University in 1987. He has a doctorate in medical genetics from the University of Toronto and subsequently completed medical training in internal medicine and cardiology at the University of Toronto. He is currently a staff cardiologist at Halton Healthcare and is also the director of the Oakville Hospital's Heart Function Clinic and the medical director of research at Halton Healthcare. In addition, Dr. Heffernan is an assistant clinical professor at McMaster University and the University of Toronto. Dr. Heffernan's research activities have been widely published in academic and peer-reviewed journals, including the New England Journal of Medicine. I will now hand it over to Dr. Durzo to begin the presentations.
Thank you very much, Chris, and Gloria, and all our folks at the Lung Health Foundation, and Dr. Michael Heffernan for joining us tonight in what is becoming kind of a very unique and novel way to deal with lung health, and that is to provide, in this case, a very important cardiovascular perspective. So thank you very much. You know, what we hope to talk about over the next 50 minutes or so is the treatment and management of chronic obstructive pulmonary disease, both from a pulmonary and from a cardiovascular perspective, because these two conditions often coexist. And as Chris has indicated, this event is supported by an unrestricted educational grant from AstraZeneca, and they don't have any conflicts to report on this. You know, most of you are familiar with our approach to mitigating bias. We try and make certain that the information we share with you is based on local, often provincial, and even national guidelines, in this case, the Canadian Thoracic Society. The topics were sort of reviewed and determined by a scientific planning committee. All the speakers and moderators and authors involved have completed the appropriate College of Family Physicians of Canada main pro-conflict of interest forms, and these are reviewed by members of the planning committee. Industry was not represented on the planning committee and did not provide input into the content of the program. And as often is the case, the Lung Health Foundation is always around to support us at all workshops and webinars to ensure that there's no bias or breach that may occur if some of us are wavering from the information we're sharing with you. So, you know, for myself, you know, if anyone is involved in working with asthma and chronic obstructive pulmonary disease, either from an educational or research perspective. I've probably worked with them. And so those are my disclosures. Here are Dr. Heffernan's disclosures as well, and they seem to be in many ways very comparable to mine. What we hope to accomplish tonight is hopefully giving you a better understanding about COPD guidelines in the treatment and management of COPD, discuss ways to approach and differentiate dyspnea from COPD and cardiovascular disease, because we often kind of treat COPD on its own, but it never really is on its own. Recognize the importance of eosinophils in COPD, explain the role of triple therapy in the management of COPD with respects to exacerbation and cardiovascular disease risk, recognize mortality reduction as a treatment strategy for COPD, and finally, to summarize patient cases relating to COPD exacerbations that are often associated with positive outcomes. You know, one of the things that we are all familiar with is that chronic obstructive pulmonary disease is an insidious condition associated with persistent symptoms and airflow limitation that is often involving both airway and alveolar abnormalities, and usually related to exposure to the typical sort of noxious particles or gases that many of us are familiar with, primarily with exposure to cigarette smoke in developed countries and other exposures from a global perspective. I think when we think about the management and the treatment of COPD, we suddenly realize right at the very beginning that it really is a comprehensive approach that involves the important role of spirometry in the early diagnosis of this condition, and getting patients to quit smoking, the importance of vaccinations, pulmonary rehab, eosinophils and their role in COPD, pharmacotherapy, and ultimately reducing mortality. And I'm going to be sort of sharing with you an approach that sort of follows these different pillars. And sort of to begin with, it's a bit of a busy slide, but what it really is saying in a very sort of simple way is that for family physicians who are very busy, it might be helpful to look at COPD in terms of its management from a day-to-day and a risk perspective. So day-to-day, we want to keep our patients under the best control with respects to their symptoms and with respects to their breathlessness. And we also want to invest in a treatment that will reduce their risk of having bad outcomes, such as exacerbations, which are often linked to cardiovascular events and often also linked to mortality. And that's really what this slide is talking about. And as I move forward, I'll get into some of these different areas in a bit more detail, but it's really, what are we going to do for patients today? And how will that affect their future risk in terms of preventing bad outcomes that can lead them to death? This is a slide from the most recent GOLD strategy, and I really just want to focus here on the bottom right-hand corner that really kind of focuses on what I just really described, and that is that when we look at things like the MRC, which is the Modified Medical Research Council scale, it's a scale that measures the level of dyspnea in a given patient. And the CAT, which is the CAT score, the COPD assessment test, is really a measure of how is a patient doing overall with respects to their COPD and how it's affecting their life on a day-to-day basis. And above these, you have three categories, A, B, and E. A and B refer to patient groups that are not at high risk for exacerbations, but may be symptomatic or not. And category E refers to patients who may or may not be very symptomatic, but who do have a history of exacerbation and an increased risk of exacerbations. And that's really the message from this slide. And when we talk about Group E patients, we're looking at patients who are having 2 or more moderate exacerbations or 1 or more exacerbation that leads to hospitalization. So we're talking about fairly sick people. And the ones below that, the lesser affected individuals, are those ones who tend to have 0 to 1 moderate exacerbations. And these is really referring to patients who often will require antibiotics or oral prednisone to get them through these events. And this is sort of our Canadian version. And I'd really like to premise and sort of apologize at the same time that as we speak, I've had the pleasure this year of being part of the Canadian Thoracic Society COPD update group. And so by the end of April, a lot of what I'm sharing with you now when it comes to the Canadian guidelines will be different. And in some ways, it will be quite different. So please bear with me. It's not that I'm withholding information, but I'm trying to share what we've been doing with where we're going with a bit of a gap there because they're not out yet. But really, it's kind of it summarizes what I've just talked about, and that is the importance to acknowledge how patients are doing day to day with respects to their dyspnea, with respects to their symptoms, with respects to their lung function impairment, and then helping them buy into a strategy where they can participate in an integrated care pathway where they are able to play a very important role in their own care by educating them about how to manage things like exacerbations and how to use action plans, provide them with bronchodilator therapy, which is the mainstay of therapy for COPD patients. And once short-acting drugs are not effective, we get into longer-acting medications. And then if those are not adequate, and even if they were, we should always remind ourselves that pulmonary rehab may be an option for many patients and should be considered because there are some very important outcomes associated with attending these programs. Oral therapies such as remfumilast and prophylactic azithromycin is an option. Long-term oxygen therapy for those individuals who are hypoxemic or who may not meet the hypoxia requirement, but may have end organ involvement such as cor pulmonale, they will benefit from long-term oxygen therapy in terms of survival. And then lastly, lung transplantation is certainly an option for many patients. There are other options which I won't get into in the interest of time, but really sort of starting off with these patients and getting them to buy into a management plan that they can be play a central role in. And the hope by doing that is that we'll be able to reduce mortality, help these patients feel better day to day, prevent their disease from progressing, improve their exercise tolerance and quality of life, and preventing and promptly treating their exacerbations. All of these items interplay in a way that in many cases allow this condition to accelerate at a very rapid rate in some patients. This slide, I think it's very appropriate. Yesterday, one of the last patients I saw was a 58-year-old gentleman, 35-pack-year smoker, hadn't seen a family doctor in a while, had never done spirometry, but certainly gave a history of being short of breath, and had a very productive cough almost on a daily basis. And when I did spirometry on him that afternoon, his FEV1 was 37% of predicted post-bronchodilator. So this person, as depicted in this slide, is symptomatic, but by the time that symptomatic patient presents to us, their lung function is often well below 50% of predicted. And that's partly because these patients try to adjust to their disease by doing less to minimize their shortness of breath. And that often will prolong the time at which they present to the clinic for the first time. So early diagnosis is very important in these patients. And there are some interesting things with COPD patients with respects to lung function that are different from those of us who don't have COPD. And here we see this green curve that shows a normal flow volume curve. And we look at what the normal total lung capacity looks like in a non-COPD patient, shown here at the bottom. And what you see here in this COPD patient is because COPD is associated with airflow obstruction, they trap a lot of air, their lungs become hyperinflated, and their total lung capacity as a result, in order to accommodate more air than should be there, their total lung capacity goes up. And this puts them in a sort of a really tough situation because now they're breathing at a level in their sort of pressure volume curve that is not advantageous for them. And by that, I mean, they have to generate more pressure to generate a given volume change. And that makes it difficult for them. And then on the other hand, then that happens during inspiration, and during expiration, they have the pleasure of having to blow air out against a lot of resistance. So these patients really, really struggle because of their airflow obstruction. And that is just one of the ways that it affects them. I talked about environmental smoke. It is the main culprit in most cases, and clinically significant COPD associated with an accelerated decline in FEV1 develops in about 15% of patients. There are many patients, I'm sure you know, who have never smoked. About a 25%, if we look at the CAN-COLD study data, will present to clinic without a smoking history, but with significant airflow obstruction. And in those individuals, they may have exposure to secondhand smoke, they may have exposure to biomass fuel combustion. And then there's other ways that the lung can be injured, and that is by folks who smoke cigars, particularly if they inhale water pipes, e-cigarettes, and certainly cannabis can have a negative impact on the lung, in some cases even more so than typical smoke. This slide really is just to remind us that those of us who've never smoked are going to experience lung function decline, whether we like it or not, because we lose elasticity over time. And patients who smoke, as depicted by the red line here, the injury to the lung is such that their rate of decline is quite dramatic compared to us. You know, you and I will decline at probably about a rate of about anywhere from 35 to 45 mils a year. These patients are declining at a rate of 75 to 150 mils per year. And the only way to get them off of that trajectory is to get them to stop smoking. That is helpful, but unfortunately, it doesn't get them back to the level of someone who has never smoked. So quitting is important, even though you don't regain what you've lost. Things like influenza, pneumococcal, and COVID vaccinations are important, and you all know about them. And there's good data to show that influenza has important impacts on mortality. Pneumococcal vaccination has important effects on exacerbations, and COVID-19 is relatively new, but has been shown to be helpful in this population as well. I talked about pulmonary rehab, and it really can't be understated, even though many of us will apologize because we often will recommend it, but it's one thing to recommend it, but it's often a very difficult thing to get access to because they're busy, and in some places there are not many of them around. But they do improve many of the symptoms that we're targeting, such as dyspnea, exercise tolerance. They improve how patients feel. That impacts the patient, it impacts the healthcare system. And longer programs tend to be very helpful. And one of the important things is to think of it shortly after a patient has had an exacerbation. Usually within a month, it seems to be the sweet spot in terms of how patients seem to benefit the most. So please think about that when thinking about comprehensive management of these patients. A little bit about eosinophils and COPD, and really the message from this slide, if we look at the y-axis, we have annual exacerbation rates versus blood eosinophil counts here on the x-axis. And really the story here is depending on the treatment that you use, and this slide refers to two treatments that you're familiar with. One is Trilogy, which is the triple combination of umeclidinium, vilantrol, and fluticasone furoate. And the other is umeclidinium and vilantrol. So one is Trilogy, which is the triple, and the other is an oral, which is the LABA/LAMA. And the message here is that if you're using triple therapy, it really doesn't matter what the blood eosinophil count is. Having a steroid in that component as part of that treatment component seems to have a favorable effect on exacerbations. In the same study, if you're using only a LABA/LAMA, what it seems to show is that as the blood eosinophil count increases, the likelihood of exacerbation activity also increases. And there's sort of a cutoff that we often are reminded of, and that is about 300 cells per microliter. So think about that. Some of us are still uncertain as to the specific role of blood eosinophils, but this kind of data certainly is intriguing and may be informative in some patients. Now, this is really a very busy slide to talk about many of the things I've already talked about. So I'm going to really simplify it for us. Going from right to left means you're going from a patient who is mildly symptomatic to more and more symptomatic and more likely to exacerbate. And in this particular area here where we have asthma and COPD overlap, I'll get into that shortly. But the real message here is as patients become more symptomatic, we go from right to left we escalate the amount of bronchodilator that we're using. And in some patients that may not be enough, even if they don't have a high risk of exacerbation, but they may be symptomatic in terms of their CAT score and their MRC score. And these are kind of like sort of cutoff numbers that we use. For CAT, it's 10 or equal or greater to 10. For the MRC, it's greater or equal to 2. So they have to be symptomatic and they have to have poor control. And they may be either at low risk or high risk. If they're low risk, the focus is on maximizing bronchodilator therapy. In some, you may have to escalate to triple to make it even better. But you always have the option of titrating back. If we move more to the right, what we see is we start off more aggressively in these patients who are symptomatic and at higher risk, and we go directly to dual therapy, whether that's LABA-LAMA or ICS-LABA, and then we fairly quickly transition to triple therapy, and then we get into some of those oral therapies that I was referring to earlier on. And again, a caveat, this will look different in about a month and a half. A quick word about asthma-COPD overlap. If you suspect asthma in a patient with COPD, then the treatment is fairly straightforward. You should initiate something that includes an inhaled corticosteroid, and that may be ICS-LABA or triple that includes an inhaled steroid. The stuff on the right here is the old gold. I've already presented the new version, so I won't focus much on that. And this is a little bit about the inhalers that we've all seen over the years. These are the short-acting bronchodilators, either by themselves or in combination here, Combivent, which was relatively new when I started off, which really only reminds me about how long I've been doing this. Then we have newer versions with newer devices. And then we get into the long-acting bronchodilators, the LABAs, which are 12-hour acting drugs. And here we have formoterol in two versions, the DPI and the aerolyzer, indacaterol in the Breezhaler, and salmeterol in the disc. And again, these are medications, with the exception of indacaterol, which is once a day. These are twice a day therapies for the most part. Then we get into the ICS-LABA drugs that you're all familiar with, the Symbicort, Advair, and more recently, Brio. There's also something called Atectura, which is mometasone and indacaterol. We don't have a slide here on triple therapies, but I will mention them. There are triple therapies such as Trilogy, as well as Bretsy, which is the newest kid on the block. And as you know, Trilogy is fluticasone furoate, umeclidinium, and vilantrol. Bretsy, and that's a once-a-day treatment. Bretsy is budesonide, glycopyrronium, and formoterol, which is a twice-a-day therapy for COPD. And then we have Enerzair, which is mometasone and glycopyrronium and indacaterol, which has its triple therapy is once a day, but its indication is for asthma at the present time. Exacerbations are important because, as we'll see from Dr. Heffernan later on, they do have consequences. They impact quality of life. They decrease lung function in a significant way. And they do result in an increased risk of death. What's relatively new for us in respiratory care is that exacerbations are to COPD what myocardial infarctions are to coronary artery disease. They are acute, they are trajectory changing, and they're often deadly. And this, for many of us, is relatively new, certainly within the last 10 years. And mortality related to an exacerbation is similar to having a myocardial infarction. And Dr. Heffernan is going to share some more information on that subject shortly. This is just really a quick slide to kind of remind us how patients may end up on triple therapy. And their course can, they may start off on a single monotherapy, such as a long-acting muscarinic antagonist like tiotropium. They may then, because of their symptomology and their exacerbation risk, quickly escalate to triple therapy with the addition of an ICS-LABA. They may be on LABA-LAMA and their exacerbation phenotype changes. They may get added an ICS, and that will get them to triple. And if they're already on ICS-LABA and they're still exacerbating or not doing well, adding a LAMA will also get them to triple therapy. Now, I'm going to talk about two pivotal trials recently involving triple therapy. The first is the IMPACT trial, which is a combination or a study comparing Trelegy versus Brio, shown here in orange, versus Anoro, shown here in green. And this is on the left-hand side is looking at data for moderate and severe exacerbations. And what you can see here is that Trelegy is significantly more effective than Brio and Anoro at reducing moderate to severe exacerbations. But when we get to severe exacerbations that require hospitalization, what we see is that Trelegy is effective, but not significantly more effective than Brio, but significantly better than Anoro. When we look at the newest kit on the block, which is Bretsy, which is the triple combination of budesonide, glycopyrronium, and formoterol, what we see here, and the reason we see 4 arms here is because the triple therapy arm had a high and low dose budesonide arm, 320 and 160, but the message really is the same. Triple therapy was significantly better than either the LABA-LAMA arm, shown here in green, or the budesonide formoterol arm, shown here in red. And these differences were significant. And so what we see here is that triple seems to be more effective than either ICS-LABA or LABA-LAMA in patients who are fairly sick. In both these trials, these patients had a history of at least 2 or more exacerbations and CAT scores that were quite high and MRC scores that would have been quite high. So these are fairly sick patients. Now, when it comes to the supporting the use of inhaled steroids, we sort of categorize it into strong, consider using ICS, or perhaps you may consider not using ICS. And where we consider the use with strong support is if patients have been hospitalized because of an exacerbation, if they've had 2 or more moderate exacerbations in a given year, if their blood eosinophil counts are greater than 300, or if these patients have a history that you think is compatible with asthma. We may consider use if they are less sick, such as having fewer exacerbations, or if they're having 1 exacerbation or so, and their blood eosinophil count is hovering between 100 and 300, but that's a soft number, I must admit. And then we probably shouldn't be using them among patients who are having frequent bouts of pneumonia if their eosinophil count is quite low, or if they have a history of mycobacterial infection. And one of the things that we often think about when it comes to managing these conditions is using prednisone and antibiotics. And typically, I'm reminded that antibiotics are really the main player in this approach because there is a mortality benefit. Prednisone doesn't have a mortality benefit, does have side effects, but may improve hospitalization stays, and it may also improve lung function. So we often will use them both. Intervening early is very important for patients, and patients who've had exacerbations in the past and who have been educated, they tend to be pretty good at anticipating and reacting to what they think is something that's evolving into an exacerbation. As I said earlier on, exacerbations can be life-threatening and life-altering. One of the things we don't talk about in this presentation, I suspect, was dealt with in the first presentation, was that the challenge we have as family physicians is that most patients with COPD don't report exacerbations to us, and so many of them are sicker than they appear to us when we're talking to them. There are certified respiratory educators involved in various programs who provide excellent support and education for patients. And this includes getting them to understand what an exacerbation is like, and then to use an action plan to manage their way through it. And this is really to summarize what I've already talked about, is that, first-time exacerbators, they're probably going to need a bit more help than someone who has had exacerbations in the past and who's had to go through that experience of managing it. And so self-management is so fundamentally important to these patients. And when we look at action plans, they look like this, and these particular action plans really revolve around, are they bringing up more sputum than usual, and are they more dyspneic than usual? And if they are, Then they activate their action plan. And I won't get into the details here because that's really sort of the main message. But once they decide that they think they might be having an exacerbation plan, then part of that plan should be, well, what do I actually do about it? And most of us will recommend that patients will have a prescription that's ready at their disposal, either in the home or at a pharmacy that can get it to them fairly quickly. And it'll tell them, when should I start my antibiotic? And when should I start my prednisone? How much and for how long? And many of you may have your choice of antibiotic and your dose of prednisone. But this is really just to kind of set the stage around the importance of promoting self-management with the aid of action plans. And before I hand it off to Dr. Heffernan, I just want to sort of finish by saying that, there are important consequences with exacerbations. And this is a study that kind of addresses that point. And it shows survival probability here on the left hand side of this graph versus time. And if you've never had exacerbations compared to those folks who've had one or two or more, or three or more, if you've had no exacerbations, you are much less likely to die compared to those individuals with COPD who are exacerbators. And one of the reasons for this is because there are important cardiovascular events that occur as a result of these exacerbations. And so identifying them early, preventing them, and managing them aggressively is very, very important. And finally, the point about mortality reduction provides me with a wonderful opportunity to hand this over to Dr. Heffernan and welcome him to this presentation.
Thanks, Anthony. So welcome everybody. And I know I'm as a cardiologist infiltrating the respirology realm tonight. And I'm hoping that's not such a rare thing kind of moving forward. As Anthony mentioned, the major reason for the increase in mortality in COPD patients who exacerbate is as a result of cardiovascular events. And I'm going to discuss that then in a moment. So to preface, the definition of COPD, this was just reviewed. It leads to skeletal muscle dysfunction, respiratory failure, diminished blood flow, and in patients with COPD and cardiovascular disease is obviously a complex interaction between the respiratory system, the cardiovascular system together. And the responses of both the cardiovascular system and the pulmonary systems as it relates to coexisting COPD and cardiovascular disease is modulated by the disease itself, but also by our therapies. And probably a good example are beta blockers, where cardiologists were very fearful of prescribing beta blockers to patients with COPD. And when in fact we know that for most individuals that is a non-issue, and when indicated should be prescribed. So next slide. So this is as an overall effect of smoking or noxious stimuli in the cardiovascular realm. It gives rise, really, it starts with oxidative stress and inflammation, and that's the beginning of everything. And cardiovascular disease is really a disease of inflammation. If you march down the left side, there's an effect on the endothelium, which then gives rise to endothelial dysfunction and atherosclerosis, which will ultimately potentially lead to plaque rupture and vasoconstriction, and this can give rise to myocardial ischemia or infarction. On the far right, if we go down that panel from inflammation, that activates platelets. So when platelets are activated, they're stickier, which leads to thrombosis, and it also can lead to impaired fibrinolysis. And so all of these paths ultimately lead to potentially myocardial ischemia and infarction. So next slide. This is a nice slide. It comes from this paper in 2012. I like it because it really gives you a nice visual of COPD and its associated comorbidities. The ones in red are the cardiovascular ones. And you can see that there is a legend on the bottom right as to prevalence of being about 50% in the large bubble and small bubble 10%. So patients with hypertension, dyslipidemia, coronary artery disease are in the realm of 50% or so in patients with COPD. To a smaller degree, heart failure, atrial fibrillation, previous stroke, or peripheral arterial disease. I must say this data is a little bit old. I think the presence of atrial fibrillation is certainly much more than 10 or 15% as suggested here, is probably more on the order of 20 or 25%. But really, the take-home message is here, a lot of comorbidities in a patient with COPD, a lot of cardiovascular morbidity as well. So next slide. Although a busy slide, I'll just take you through this because I think it really is relevant. So if you look at the presence of cardiovascular morbidities and what increases mortality, these numbers on the slide are versus somebody with COPD alone. So in the top left, if you have COPD and you have ischemic heart disease, you have a potentially up to a 50% increase in your mortality by adding ischemic heart disease to your card hand, if you will. If you add atrial fibrillation, about 50%. If you add diabetes, up to about 70%. And that's not surprising because the majority of patients with diabetes also have cardiovascular disease like ischemic heart disease. If you have heart failure in COPD, it's probably the worst case scenario. Many of those patients also, of course, have concomitant ischemic heart disease, and mortality is upwards of 90% in comparison to COPD alone. So next slide. And, as Anthony alluded to, COPD exacerbations are associated with an increase in all-cause mortality. This is a good slide, which demonstrates that about 20% of patients with COPD will pass away within 1 year of their first hospitalization. So it's a pretty sobering number. And the majority of this mortality is cardiovascular in nature. Next slide. And that is highlighted here. So after an exacerbation, there's a twofold increase of heart attack in the first 1 to 5 days, and about a 50% increase in strokes in the first 1 to 5 days. If you look up to, say, day 10, for instance, there's an ongoing and potentially increased risk in myocardial infarction and increased risk in stroke. So the cardiovascular events that occur in the first 10 days after a moderate exacerbation are significant. And next slide. And the risk doesn't stop at 10 days. So there's a 4-fold increased risk within the first 30 days. And this is a combined endpoint of cardiovascular death, MI, stroke, and now add unstable angina or TIA. Same endpoint, there's a 90% increase if you then have a look out to the 1-year mark, from 3 months to 1 year. So there's an upfront risk, which is certainly significant, and there's a persistent or residual risk, as we like to comment in cardiology, in patients with COPD as you move along the timeline. Next slide. It's not surprising that this is occurring, though, because COPD and cardiovascular disease, they share risk factors. Exacerbations give rise to hyperinflation, hypoxemia, inflammation, as mentioned previously. All of those things will increase cardiac afterload. They potentially can reduce left ventricular ejection fraction. They can increase the risk of plaque rupture, and I mentioned why just previously with the increase in inflammation. And all those then potentially increase the risk for cardiovascular events, primarily MI, stroke, and heart failure. So next slide. The challenge is sometimes just making the diagnosis. COPD and heart failure share a lot of common signs and symptoms. And I know this is it's a bit of a shock value slide more than anything else, but at the top, common symptoms are dyspnea, reduced exercise tolerance, fatigue. You are not going to be able to sort out if somebody has heart failure or COPD based on those type of symptoms. You need some other kind of clue. And so things in blue that would make you more likely to presume that this is COPD is chronic cough and sputum production, history of smoking as you move down the path. If you actually manage to get spirometry in a timely way and you find that the FEV1 over FEC is less than 70%, all of that certainly will lead you down a COPD path. If, on the other hand, signs and symptoms are a little bit more suggestive of heart failure, elevated JVP, if you can hear a third heart sound and isn't a busy office or emergency department, that would be fantastic. something about the history that might lead you that way, or the ECG, perhaps atrial fibrillation, a heart rate of 150, shortness of breath. Okay, that's perhaps the AFib. And then echo and BNP. And I do want to spend a little bit of time on echo and BNP as very important tools to sort out whether or not a patient has COPD or heart failure. Next slide. So a respirologist's view of their approach to sorting out if somebody's dyspneic and if it is COPD or pulmonary in nature, next slide, is this. A chest x-ray, an ECG to confirm sinus rhythm, an echocardiogram to assess heart function, and the echo will also give you the pulmonary artery pressure and oximetry. You know, a routine panel, ruling out anemia, ruling out thyrotoxicosis, ruling out end-stage renal disease, spirometry as mentioned, and potentially a methylcholine challenge test if necessary, cardiopulmonary exercise test if necessary. And then ultimately you get down to, you know, is it pulmonary in nature? Is it cardiac ischemia? Is it obesity and deconditioning? Is it normal? Is it psychogenic? So that is a general respirology approach to sorting out dyspnea. So next slide. The cardiology approach is a little different and really relates to biomarkers like BNP and an echocardiography to assess LV function. So next slide. So as mentioned, the accuracy of a history and physical is not entirely useless, but pretty close. So dyspnea is a flip of the coin as to whether it's heart failure or not. You can't rely on it. You can see that the sensitivity for a lot of things that people will tell you about fatigue and weight gain, orthopnea, PND, the sensitivities are really quite low. The specificities for some of these are actually quite high if you see them and if you're trained and if you can look for them. So an elevated GBP, an S3, an S4, if they truly do have orthopnea and PND and you elicit that from your history, those are powerful. So those might lead you to think that, yep, this is a patient with heart failure. But patients don't always kind of report and can tell us what will respond to their questions. The flip side is sometimes the environment that we're practicing in makes it very difficult to evaluate things like S3s, S4s, and elevated JVPs. So we need a little bit of help. So next slide. The differential diagnosis for dyspnea is large. Pulmonary causes are extensive, as mentioned here. Cardiac causes are certainly several, tachyarrhythmias. Angina sometimes may not be chest pain. It may just be shortness of breath as an anginal equivalent. Heart failure, of course. And then there are other causes, panic attack, renal failure, thyrotoxicosis, other things can cause dyspnea. So we do need some help. So spirometry is certainly helpful. And next slide. But BNP is an NT-proBNP in particular is crucial. So you can forget everything I say tonight, but if there's one thing you remember, please remember this. So NT-proBNP is a covered lab in the province of Ontario. Patients do not have to pay for it. You can order it on any of your standard lab recs, bottom right-hand corner, just free text it in the bottom. It is a powerful tool to help you sort out if a patient has dyspnea, whether it's cardiac or non-cardiac in nature. If the number is low, it's not heart failure. If the number is high, it is heart failure. But the type of heart failure, we can discuss. But this is an important biomarker. You should recognize that it's available. I gave a talk to our respirologist in our town just 2 months ago, and they were unaware of it. And now I'm sorry I mentioned it, because now they're ordering it frequently and they're identifying more and more patients with heart failure with preserved ejection fraction than they knew existed in their practice. Next slide. So as a reminder, BNP stands for brain natriuretic peptide. It's an unfortunate name. It's found in cardiac ventricles. It is released as a result of stretch in the cardiac myocytes. When it's released, the BNP is actually the active hormone. It goes to the kidneys and it will promote a diuresis. So it is a evolutionary positive benefit. It will allow us to reduce our volume overload if we're in heart failure. The labs, some labs measure BNP. I think this is where I forgot to mention, it's really critical if you're ordering this for your patients in the outpatient labs, order NT-proBNP. That's what the province of Ontario covers. It is free. If you make a mistake and you just write BNP, the lab will charge them $75 because they're going to do the lab that you're requesting. So don't order BNP, order NT-proBNP. Next slide. This is how good it is to distinguish causes of dyspnea. I'm sorry, everything got kind of shifted. So COPD in blue, heart failure in red, number of BNP about 38 or 40 in a patient with COPD, but a patient with heart failure on the order of about 1,000. It makes it very clear. It was super helpful in the emergency department, but now available to clinicians in the outpatient practice. Next slide. So this is a really good example of a patient in my practice not that long ago, where this kind of really helped. So she has a history of smoking, a 50-pack year history. She's on a LABA ICS combination. She has hypertension, diabetes, atrial fibrillation, and has had a previous LAD angioplasty. A pretty typical patient in the practice. She has a 6-week history of increased dyspnea. She always has a little bit. She has no change in her chronic cough, marginal increase in her sputum production. She can't really report whether it's changed that much. She always has a little bit of edema. There's been no change. She doesn't report any angina. She knows what it feels like. She has chronic 2-pillar orthopnea, occasional PND. Again, nothing much different. No fevers, no COVID-19 contact she's aware of. Her family physician did see her, prescribed an antibiotic a few weeks ago. There's no real improvement. So next slide. So to summarize, she has known COPD and she is treated for it. She has diabetes, atrial fibrillation, and cardiovascular disease. She is a known patient who is at high risk for an adverse cardiovascular event if she is exacerbating. She's a high-risk patient. So next slide. The thing is she in heart failure or is this a COPD exacerbation? So she's hypertensive. Her JVP is upper limit of normal. It's not helping very much. There is an S4, so it kind of makes you think there might be heart failure. She has decreased air entry consistent with her COPD. She has inspiratory crackles, doesn't help a lot. She does have edema, and she always does. Her COVID test was negative. Her chest X-ray shows bilateral airspace disease. The white count's marginally elevated. And the high sensitive troponin is not normal, but it's not high enough to make us think heart attack. But it's definitely above the upper limit of normal. So next slide. She gets an echo right away. She happened to present to the clinic and her ejection fraction's normal at 62%. Her NT-proBNP comes back and it's 122. It's low. This is a very clear diagnosis of COPD exacerbation based on the BNP, and her bronchodilator therapy is adjusted accordingly to improve her outcome. This is where the echo wouldn't have provided any help to you. If you saw that her ejection fraction was 20%, for instance, it might make you think about heart failure. If the BNP came back at 800, 1,000, 2,500, you would most definitely be thinking about heart failure. But a number coming back like this, 100, 200, 250, with this kind of symptom profile, this is an exacerbation of COPD. Next slide. The reason I'm going to end with a couple of these slides is the trials that Anthony was mentioning, the Ethos trial, the IMPACT study, those were studies looking at triple therapy and exacerbations. So certainly not in a cardiologist realm, but there were some secondary endpoints that we're looking at, and those were mortality. Definitely starts to fall into my field. The IMPACT study was the first one to show a significant reduction in all-cause mortality over the course of the entire study. The benefit was really seen, as you can see here, in the first 90 days, where the forest plot has a reduction of about 75% reduction in mortality in comparison to standard therapy in the first 90 days. And this is attenuated as time goes on. But it was certainly thought-provoking that triple therapy could have such a powerful effect on mortality. Next slide. And this was then seen also in the Ethos study with the new kid on the block that Anthony mentioned. And so The blue line is the one at the bottom. So this is the higher dose of budesonide. Again, this was a secondary analysis, but there was a 49% reduction in mortality, all-cause mortality. And I can tell you that when you look at why these patients were passing away, this was primarily driven by a reduction in cardiovascular mortality. So it jives with all the information that has been presented and observed in the past. So this is now why a cardiologist is speaking to you tonight, because there is going to be renewed interest from the cardiology field in triple therapy in the treatment of COPD exacerbations, since it would appear to be reducing cardiovascular mortality. Next slide. Why is that the case? To be perfectly honest, nobody really knows. I favor the middle hypothesis. So if you reduce exacerbations, we do know that fewer exacerbations reduce cardiovascular events. So it's probably the ICS lowering exacerbations that is the driving force, but reducing hyperinflation, certainly a possibility. Reducing inflammation, and we know inflammation is a key trigger for acute coronary syndromes. Also, might be a absolutely valid hypothesis here with inhaled steroids. Next slide. So to summarize from my section, so patients with cardiovascular disease and COPD share many common comorbidities. The impact of a COPD exacerbation really goes beyond the lungs. There's an increased risk in serious cardiovascular events, and including myocardial infarction, stroke, and death. NT-proBNP, please remember that, very useful tool in distinguishing dyspnea in patients, whether it's heart failure or COPD. And it would appear that single inhaler triple therapy can reduce all-cause mortality, primarily driven by cardiovascular mortality reduction in patients with COPD. So thank you for your attention, and I'll hand it back to you, Anthony.
Excellent. You're on mute there, Dr.
Guys,
Rizzo.
Thank you, Chris. Thanks very much, Dr. Heffernan. That was excellent. And I think we can open it up to questions now. And I think there is one in the chat that I saw about managing exacerbations and the use of antibiotics and the really important issue about overuse of antibiotics, I think, was sort of an implication of the question. And how do you choose? That's a great question, and I think there have been studies to show that look at the sensitivity and specificity of having a purulent-like sputum is a really good predictor of response to antibiotics. In fact, it's the best predictor. But I think the question is also important because it kind of highlights the reality that in many cases COPD exacerbations are driven by viral infections, and sometimes it can be a real challenge. So the best way to handle it, I find for myself, is just to really see if you can nail down that whole issue about is there a change in the quality and the quantity of the sputum, and if you can tease that out of the patient, then chances are that they may be presenting with a bacterial infection, and that they might benefit from antibiotics.
Yeah, excellent. I don't see any other questions in the chat, but if anybody would like to come off mute at this point and ask your question now. Otherwise, we can also look at the chat if you feel more comfortable putting it there.
Dr. Heffernan, I had a question. I love the case that you showed. It made me think of some of the challenges in interpreting NT-proBNP in patients with AFib. Because in those folks, as you know, the cutoff is much higher. And I wonder if you can sort of talk around that and how you sort of incorporate an AFib background in a patient who is coming in feeling short of breath? How do you determine, is that an AFib phenomenon, or are these patients really in failure?
That's a fantastic question. And to be perfectly honest, the BMP that this patient had is lower than you would expect. I made it such a way so that it's very clear. So to Anthony's point, if a patient has atrial fibrillation, you double what would be considered the lower limit of normal. So for instance, if I think we can accept a BMP of 200, for instance, and less as something that is not clinically significant as it relates to heart failure. But if a patient has atrial fibrillation, that cutoff is 400. And having been a principal investigator in numerous heart failure studies, I can tell you that 600 as a BMP level is the bare minimum entry criteria for any heart failure study. So 600 is a nice number to remember. And if patients had atrial fibrillation in those studies, they usually had to have a BMP of 900 or 1,000. So that's setting the bar fairly high. But I think it's worth remembering, 200 is a good number to remember. And if they have AFib, up to 400 is probably still not heart failure or clinically relevant. My question to you, Anthony, is somebody who is kind of learning all of this and refreshing, and was triple therapy seems to be so good. And I'm not entirely sure from a cardiology perspective why there's been so much hand-wringing about just not prescribing triple therapy to everybody.
Yeah, that's a great question, Mike. I think, I think it's kind of interesting because I think there's a bit of an elephant in the room for us, because unlike our cardiology colleagues who, have been, for years now, maybe even decades, doing these very large, robust mortality trials, where the information gathered from those trials is so compelling that changes are made. And I think we could argue that even in those large robust trials, you're looking at in many of these trials, it was sort of secondary prevention. These are trials where people are already sick. And I think we have sort of been vulnerable to the challenge of maybe treating COPD earlier out of fear that the numbers needed to treat in milder patients would be so large that it kind of scared us away from doing these trials. But I think knowing what we now know and recognizing how we've approached the management of COPD, in some ways, it seems counterintuitive to primary care, because it's kind of, we're waiting for patients to get really sick before we get really aggressive with them, which in some ways does make sense because we approach other conditions in a similar way. But, for example, with diabetes now, there are, I think, parallels now with diabetes, because many of us now are getting very aggressive very early on because there's so many different benefits that are afforded by these different treatments. And so I think to really address your question, I think we're starting to ask the really important question of, is there some benefit and are we now really obliged to do trials in milder patients that we treat aggressively to see whether those treatments can have an impact on cardiovascular outcomes over a long-term period? And I think, to maybe answer your question sort of from another perspective, I think what these triple therapy trials are showing us maybe, and I think you had a great slide on how inflammation affects the endothelium, and how perhaps maybe, and when we factor in that COPD is not only a pulmonary condition, but a systemic condition, one wonders if we're missing out on opportunities in these patients who may have mild COPD, but who may have well-established or evolving cardiovascular disease. So I think you raise a really important point, and certainly some of us are beginning to ask these questions about, is it time to design trials that are looking at intervening at a much earlier stage?
Excellent. Actually, you finished exactly. It's 8 o'clock right now. So that was perfect timing. I mean, we can go over a little bit if someone has one more question. Can do it quickly if you have a pressing question. Otherwise, we will bring it to a close. So thank you very much. That was wonderful, very informative, very practical, very comprehensive presentation. So thank you, Dr. Durzo and Dr. Heffernan for their presentation. Please take time to answer the evaluation questions that will appear in your browser at the close of the event. We'd like to thank our partners, AstraZeneca Canada, for sponsoring this evening's presentation. We want to thank everyone for attending the presentation as well, and encourage you to join our Lung Health Network at lungnetwork.org to learn all about our upcoming programming. And please enjoy the rest of your evening. Good night.